Evening, everyone. So it's a great pleasure to welcome you all for today's session, Advances in Common Cancer Care 2025. And I would like to invite Dr. Abhinav Narvaria, sir. So he's a consultant medical oncology, Manipal Hospital, Delhi. So it's over to you, sir, for our opening remarks. Thank you.
So good evening, everyone. Welcoming you all in this webinar named Advances in Common Cancer 2025, in which we will be sharing recent advances in all the common cancers which are in India, like the most common ones: breast, lung, and head and neck. So starting our session with in this webinar, we will be having recent developments like new immunotherapies in lung cancers, what all has changed in breast cancer, in head and neck cancer, and we will be discussing about almost every part of the management of all these cancers. So starting our webinar with Senior Consultant Pathology in Rajiv Gandhi, Dr. Sunil Pasricha is a senior histopathologist in Rajiv Gandhi Cancer Institute, and he will be sharing about the biomarkers of the lung cancer. Nobody can think of treating lung cancer without using biomarker. In this era of treatment of lung cancer without biomarkers, you cannot go ahead with the treatment. It has changed the paradigm of lung cancer treatment like anything. Uh, Almost all 50% of the lung cancer adenocarcinoma have some sort of mutation in which a few of them are targetable, and we all know that the treatment paradigm has really changed after the advent of all these biomarkers. So handing over the screen and mic to Dr. Sunil Pasricha. Thank you, sir, for joining us, and you may continue it.
Thank you, Dr. Abhinav. Am I audible?
Yes, sir, you're audible.
Okay. Thanks a lot for inviting me. And since the topic given is the biomarkers in NSCLC and time is just 15 minutes, so I have just concentrated basically more on the driver mutations only. Biomarkers of immunotherapy, we can take some other time because in 15 minutes it won't be able to cover everything. It will be just a touch and go situation. So I'll starting with the my presentation. I'm just sharing my slides. I hope they are visible.
Yes, sir, make it full screen.
Yeah, I'll do that. So it's full screen now.
Yes, sir.
Okay, so it's moving. Okay, so I'll be talking about the established and emerging biomarkers in advanced or metastatic non-small cell lung cancer. So the role of pathologists in this era is not only just to diagnose the lung cancer, but also to find out the driver mutations so that the patient can be put on the targeted therapies, because we know that the prognosis and the overall survival is statistically quite significantly superior when the driver mutations are detected, and at the same time when the patients they are put on the targeted therapies. So majority of these common and uncommon driver mutations, they are basically targetable with a FDA approved agent or something which is on the clinical trial. And in the last 1 decade, we have actually seen that there has been a very unprecedented evolution of therapy in the lung cancer. And we have realized that it is not a single disease, but it's a heterogeneous group of many diseases. So till recently, we have grouped the biomarker into the test that we do for after the histopathological diagnosis of lung cancer into two broad categories. One is the minimum necessities, which are must do tests. Other is the recommended, that is should do tests like RET, MET, HER2, KRAS, and TRK. But with the recent wealth of molecular information, we have realized that there has also been a potential application even in the uncommon mutation as well, like exon 20 insertion mutation and so on, which I will cover subsequently as they when they come. So starting with the established biomarkers, we know that EGFR mutation is the most robust predictive biomarker for the response to EGFR TKI. And in Asian population, especially lung adenocarcinoma in non-smoker females, up to 50% incidence has been seen. Therefore, a great effort has been made to standardize these diagnostic tests, and approximately 90% of the EGFR mutations, they consist of either a deletion in exon 19 or a point mutation substitution at L858R in exon 21. So two FDA-approved kits have been there. One is the Cobas EGFR mutation and other is the QIAGEN. And these tests are highly sensitive, can detect the mutation in the sample with the tumor infiltration concentration as low as 10 to 20%. And at our institute, we are using the Super ARMS EGFR mutation detection kit. So, with the historically, when the first generation EGFR TKIs were used, the mechanism of resistance was very common and that too early. And the most common mechanism of resistance was T790M. Besides other factors, also as you can see in the diagram, which contributes to 1 to 5%. So, but the most common is the T790M, for which osimertinib was the drug of choice. But in 2018, FDA has approved osimertinib, which is the third generation TKI, as a first line of treatment for a metastatic NSCLC. That this was based on the FLORA trial, which shows encouraging results in which osimertinib improved the progression-free survival. So osimertinib is active against not only for the common EGFR mutation, but also for the less common EGFR mutants like exon 18 G719X, exon 20 768I, and the peculiar insertion exon 20 mutations. Because all other exon 20 insertion mutations, they are resistant. Only this peculiar exon 20 insertion mutation that still responds to osimertinib. And exon 21 L861Q, and some others are also there, which are having a very less frequency. And also osimertinib is active against the first and the second generation resistant EGFR T790M mutated protein. In 2024, FDA has approved osimertinib with platinum-based chemotherapy for the patient with a locally advanced or metastatic NSCLC based on the encouraging results in FLORA-2 trial. And the approval was for the patient whose tumor had EGFR exon 19 deletion or 21 L858R mutation. And you can see here that the PFS of the patient with so there are two graphs. The left side is the patients having the CNS metastasis at the baseline, whereas on the right side, the patients were having without CNS metastasis at the baseline. So in both the graphs, you can see that there is a superior PFS when the patient was put on osimertinib plus platinum-based chemotherapy as compared to osimertinib alone. But one thing is that on the left side, if you see when the patient were having a CNS metastasis, the prognostic separation of the curves was much more superior and distant apart as compared to patient without CNS metastasis. And also amivantamab plus chemotherapy with or without lazertinib improves the PFS and intracranial PFS versus chemotherapy in the population with a limited option that remains after the disease progression of osimertinib. So when there is a osimertinib resistance is there. And also amivantamab and lazertinib show superior efficacy to osimertinib as a first-line treatment in EGFR mutated advanced NSCLC. And the secondary analysis from the phase 3, and based on this secondary analysis from the phase 3 Mariposa study, the patient which are with the biomarkers of high risk, which have a poor prognosis, like for example having a TP53 core mutation, detectable circulating ctDNA at the baseline, or liver or the brain metastasis at the baseline, amivantamab plus lazertinib demonstrated significantly improved PFS, but as compared to osimertinib in the patient with biomarkers of high risk. Coming to the ALK rearrangement, more than 20 different variants has been detected, and the impact of heterogeneity of the response to ALK inhibitor has not been fully elucidated. And the incidence is seen in approximately 5 to 8% of the patients, quite often seen in young and non-smokers. And we know about these methods of identification. These tests have stood the test of time. The FISH and the most commonly we are using ALK. Now it's almost now going to be almost a decade that we are using that FDA-approved D5F3 clone from Roche Ventana. And in 2014, the introduction of quizartinib, the first generation ALK inhibitor, revolutionized the treatment for the ALK fusion positive NSCLC. However, the resistance invariably develops, often progression in the brain. And during the past 5 years, there has been a significant advancement with the approval of second generation and third generation drugs like lorlatinib. And the newly approved ALK inhibitors like brigatinib and lorlatinib, they provide additional options for the first-line ALK targeted treatment options, and also demonstrate improved clinical efficacy, especially in the CNS metastatic cases and in cases where the certain ALK mutation may arise as a resistant mechanism to the conventional ALK inhibitors like quizartinib. And they also prolong the life of the patient with ALK fusion positive NSCLC up to 5 to 7 years, which is very commendable. Coming to the ROS1 rearrangement, so it is seen, the incidence is seen in 1 to 2%, and the most common, the translocation that takes the partner of the ROS1 is the other gene is that is the CD74. And this rearrangements, they are sensitive to the ROS1 inhibitor, crizotinib and entrectinib, which has been FDA approved for the patient who are treatment naive or post chemotherapy. And the preferred method of detection is the FISH as a break apart test, or NGS, which is now recommended as a part of the multi-gene assay. IHC, very important to note that immunohistochemistry is only an effective way of screening. So if the test is positive by immunohistochemistry, the bottom line is one has to confirm with the FISH or NGS. And recently in 2023, FDA has approved repotrectinib for the locally advanced metastatic ROS1 positive NSCLC who has previously received a ROS1 TKI in addition to the patient who are TKI naive. And this was based on the encouraging result of the Trident-1 trial. And repotrectinib has shown to be effective against the tumor with the resistant mutations, including the commonly mutant mechanism mutation is that G2032 that can cause crizotinib and entrectinib to stop working in the patient with the initial response. Coming to the BRAF mutations, the incidence is seen in around 1 to 3% of NSCLC, and these NSCLC patients who progressed on chemotherapy, the combination of BRAF and MEK inhibitor, that is dabrafenib plus trametinib, has been approved by FDA. And again, the preferred testing method is the PCR sequencing as a single gene, but preferred is NGS as a multi-gene assay. In October 2023, the FDA has approved encorafenib with the binimetinib for the adult patient with metastatic NSCLC with the BRAF V600E mutation as detected by FDA approved tests. The clinical because based on the clinical implications of the phase 2 PARO study. Coming to the emerging biomarker, exon 20 insertion mutations. So in the category of EGFR mutations, the approximately 10% of patients have the EGFR exon 20 insertion mutations, which occur as the in-frame insertion mutations in EGFR kinase domain. The demographics are quite similar to the conventional EGFR mutations, like most common seen in the young female non-smokers. However, these mutations, they had a lower, the patient with these mutations, they had a lower overall survival and PFS than compared to the patient with the common EGFR mutations. The testing method and treatment, the recommended method is only NGS because the heterogeneity of EGFR exon 20 insertion mutation is quite high. So the PCR-based testing has a very poor sensitivity. So a big no for this type of testing platforms for if you are anticipating exon 20 insertion mutation. Two targeted therapies approved by FDA, that is amivantamab plus or mobocertinib. Initially, they were approved for the treatment of the locally advanced metastatic NSCLC harboring these insertion mutations who has progressed after prior chemotherapy. But because of the encouraging results in the Papillon phase 3 global study, which it was tested along with the chemotherapy in the first line, and one can see that there is a good prognostic separation of the curves when the patient was put on the amivantamab plus chemotherapy as the first line. And last year, the FDA has approved amivantamab plus chemotherapy as a first-line treatment for the patient with locally advanced metastatic NSCLC having EGFR exon 20 insertion mutations. MET exon skipping mutation or amplification is also a mechanism of the dysregulation of the MET pathway. And what is the characteristic of the exons, MET exon 14 skipping mutation? They are seen in 3 to 4% of metastatic NSCLC cases. They can be associated with amplifications, copy number variant, quite often seen in female, elderly, and non-smokers, and they are highly predictive of response to MET inhibitors. MET exon 14 skipping mutations, they are also independent indicator of poor prognosis, shorter overall survival in NSCLC patients. MET amplification is also a mechanism of MET dysregulation, and the amplification is regarded as a primary driver gene and one of the main mechanism of the EGFR TKI resistance. Initially, when the patient were put on the first generation TKIs, and depending upon the assay and the positivity cut point used, the occurrence of de novo MET amplification is around 1 to 6% in lung cancer, and many studies have actually shown association of MET amplification with the overall survival. However, what is the meaningful MET amplification? The high amplification when the ratio of MET to SEP7 is more than 5 or the MET gene copy number more than 10, that appears to be the most meaningful and strongest predictor of true MET-driven tumor, and that is seen in approximately 0.4% of the lung adenocarcinomas. So drugs approved are capmatinib based on Geometry trial and tepotinib based on the Vision trial. HER2 mutation, they are seen in 2 to 4% of NSCLC tumors, common in non-smoker females. Majority of them, they are in-frame insertion in exon 20, and they have a worse overall survival than other subtypes in lung cancer mutation consortium. NGS is a recommended platform to test, and early phase clinical trials suggested that the patient with the tumor harboring these mutation who progressed on chemotherapy may respond to trastuzumab-based regime. And recently, it's not recently, actually in 2023, the FDA has granted accelerated approval to plan trastuzumab deruxtecan for HER2 mutant NSCLC. And RET rearrangements, so the RET gene they encodes for a cell surface tyrosine kinase receptor. They are identified in 1 to 2% of lung adenocarcinoma, quite often seen in young, never or light smokers. Again, NGS is the recommended platform to test. FDA has approved selpercatinib and pralsetinib for the metastatic RET fusion positive NSCLC. And the pralsetinib treatment produced robust efficacy and was generally well tolerated in a treatment-naive patient with advanced RET fusion positive NSCLC, with the intracranial response rate was around 70% in this short data. The NTRK fusion, the NTRK gene encodes the tropomyosin-related kinase A. The prevalence is approximately 1%. Larotrectinib and entrectinib are the two FDA-approved oral TRK inhibitors which are approved in a tissue-agnostic fashion. Again, the recommended testing platform is NGS, although we are using this clone IC, but that is just required only as a screening modality. One has to confirm it with the NGS later on. Standalone tests are not cost effective or feasible, so the choices platform is the NGS. And although many patients have a long-term disease control, but advanced NTRK fusion positive malignancy eventually developed resistance to TRK inhibition. Even 2-3 patients that we have seen in our institute also, initially they responded very phenomenally, but eventually they had a recurrence or the progression. So the resistance might be caused by the acquisition of the NTRK kinase domain mutation, and the second generation inhibitors like they are in clinical trials and which can show some promises to overcome some resistance mutation. Lastly, the NRG1 fusions, they constitute an integrate family of the structurally related cellular growth factors, including all the form of NRGs. And they are the fusion involving the NRG1 are rare, approximately less than 1% prevalence is there. The prognosis of the lung cancer patient with this NRG fusion protein is not so promising. The NRG fusion has a higher probability of extrathoracic metastasis and a larger tumor size. And prevailing literature have suggested the poor activity of chemotherapy and immunotherapy in the NRG fusion cancer. And again, the recommended method is NGS, and zenocutuzumab and seripinumab have been shown to be potentially beneficial for these NRG1 fusion cancer, and they act by inhibiting the heterodimerization of the ERB2 and ERB3 receptors. And recently in 2024 December, the FDA has approved zenocutuzumab for NSCLC with the NRG1 gene fusion. The KRAS mutations, which activate a number of downstream signaling pathways, they are observed in approximately 25% of lung adenocarcinoma. But in the category of KRAS mutation, approximately 45 to 50% are of G12C. So, and overall, 13% of all the lung adenocarcinoma patients has a KRAS G12C mutation. But at our institute, we have seen that that incidences are approximately 5 to 6%, not more than that. And sotorasib and recently adagrasib approved by FDA for the KRAS G12C mutated locally advanced or NSCLC metastatic who has received at least one prior systemic therapy. And adagrasib has shown encouraging results in phase 2 PISTOL-1 trial, and additionally the adagrasib has shown therapeutic effect on NSCLC with the intracranial metastasis as well. So optimizing the emerging biomarker identification, that's why NGS is now a preferred method to detect these biomarkers over the single gene. It's a tissue proficient. It's a one platform, and so you can have all the results. 10 nanogram input of DNA and RNA is sufficient. It's a resource proficient. One experiment, one platform. Variant allele detection cutoff is around 5%. Hence, it overcomes the detection. It overcomes the problem of low tumor fraction. It maximizes the detection of actionable and other driver mutation, and based upon the detection of the alteration, whether it's a tier 1, tier 2, the patient can receive the targeted therapy, or if a tier 3 alteration, patient can subsequently recruited in the clinical trial, which is the need of our in the metastatic NSCLC. And NGS can also use plasma as a sample. However, turnaround time is still a problem. And recently, liquid biopsy has also cemented its place in the management of lung cancer. The advantage is that they have a very good high concordance rate, the rapid turnaround time, they are minimally invasive, can be repeatable over time, they have a better capture human heterogeneity and clonal evolution. And NCCN has also advocating the use of liquid biopsy not only as a first approach when the tissue is not available, but even also as a complementary approach when you are dicey that the tissue is somewhat less with a less tumor fraction. You are not sure whether the result will come with a very certainty of the confidence. So you can use the liquid biopsy along with the tissue as a complementary approach. So to conclude, there is an extensive role of biomarker testing in the metastatic or advanced NSCLC. There is a potential application in uncommon mutation and emerging biomarkers. The broad molecular testing (NGS) helps investigators to identify additional unrecognized targetable mutations for the development of new, highly specific targeted drugs. And it's incumbent upon pathologists to make the testing reliable by optimizing all the three pre-analytical, analytical, and post-analytical steps. Thank you very much. Would be happy to take any questions if you have.
Thank you, sir. Thank you for such a brainstorming session about biomarkers in the lung cancer. We these days cannot imagine to treat lung cancer without biomarker testing. And as you emphasize that, firstly, you have to do a NGS because a broad NGS, not a limited one, a broad NGS will give you mutation in the first place, because after that, sometimes you're short of tissue, or maybe liquid, you have to use liquid biopsy. But the most important point remains that once you detect a patient with lung cancer, you have to perform a comprehensive NGS panel, because these mutations, not are only predictive, but also prognostic about, they also explain about the prognosis. As you know, KRAS is common in around 25% of the patients. Still, we are not using medicines for KRAS, but as soon as it comes in India, it will be one of the blockbuster drug. Thank you, sir. Thank you for joining us.
Thank you.
So, team, can we go ahead with the second session?
Yes, sir.
So, good evening. The second session for today's webinar will be on Tecentriq, lighting new hope in extended stage small cell lung cancer with 6-year overall survival. And for this, I would like to invite Dr. Chandragowda sir, who has been a continuous mentor for me. And wherever I am, he plays a very important role in that. So thank you, sir, for joining us and handing over the screen and mic to you, so that for this session. Thank you.
Thank you, Abhinav. Thank you, thank you, Rosh. So, without much ado, I'll be just do what is assigned to me. That's the extensive stage SCLC, the role of atezolizumab, and 6-year overall survival reported. These are my disclaimers. So, when you talk of drug development in SCLC, that's been really a challenge. And we have seen from the earlier era of only chemotherapy, adding any chemotherapeutic or any targeted agent, be it a VEGF, IGFR, mTOR, EGFR, SGF. So what that has never resulted in any kind of a benefit in this particular dead disease. So this is a case of we have a lot of good examples of a SCLC or a high grade NETs with the IO, that is atezolizumab maintenance, and they're doing well since last almost 4 years, which is really commendable. So that's what it is. And this 48-year gentleman came with a history of breathlessness, and there was no significant past history, and there was a large mediastinal mass, and then you can see that there were the metastatic, there was extensive stage disease. There was no brain mets though. There was SVC, wheezed dyspnea because of mediastinal disease, and he was well preserved. When you talk of SCLC, it has definitely a high tumor mutational burden, A lot of mutations do occur, and there are a lot of resistant mechanisms. Initially, there is a sensitivity, and then automatically they spill out the chemotherapy and develop a secondary resistance. So hence, initial response is warded off, and then subsequent chemotherapies would not act, and the PFS becomes less and less, and the survival was much lesser. So until we in 2018, the thought of addition of immunotherapy came into vogue, and then when initially in the WCLC, and then ESMO, and down the line, in September 2019, the Atezo plus chemo was the first approved drug by EMA in the first line SCLC because of the advantage it has shown. And as per the IMPOWER 133 trial, so this was a trial with schema and next stage is a CLC with a good performance status, and they're randomized in patients with atezolizumab with or without a chemotherapy, with chemotherapy or without atezolizumab. So then when they respond after 4 cycles, they were given atezolizumab maintenance. So and then this actually was stratified as per the male or female performance status and brain metastasis. So it was given in combination with etoposide and carboplatin over 4 cycles at a recommended doses. There's a lot of debate of 4 versus 6, and that we can decide. That's a clinician discretion. If you achieve adequate response post cycle, you can stop and maintain with the immunotherapy. And if the adequate response is not happening, if it's only a partial response, you think that the patient needs doesn't have a toxicity, may extend up to 6. That's how we take into we decide clinically. So this patient was initiated on atezo and a chemo combination, and post 4 cycles there was a marked symptomatic improvement as expected, and then it was put on atezolizumab maintenance. This is the response, and once a patient responds, the more than a pass or more than some sort of a response, the PCI is permitted as per this trial. The 44 patients in IMPOWER 133 received a PCI, and whether you need a consolidative thoracic radiotherapy, there are a lot of trials and the meta-analysis which have been done. Yes, if there should be some sort of residual disease post-treatment. If that is there in a clinical practice, we also end up giving consolidative thoracic radiotherapy in these patients. Now, 6-year survival in patients extensive stage treated with atezo combo as per IMbrave 8 trial. So this is a 6-year OAS data. If you can see down at 6 years, 11% was still alive, and it was not available as per IMPOWER 133. This is actually extended study of IMPOWER 133, where they were followed up by Umbrella 8 trial, and then this was seen as per that. So what is the evidence that is seen for the long-term OS data in this particular so far? In this segment of an SCLC, extensive LCSA, these are the trials which are shown, and the longest follow-up is with the IMPOWER as it started early, and at 6 year 11% with them. And the Caspian with the durvalumab has a 3-year OS data, and the Pembro has around 3 years of OS data. So the longest follow-up was seen with the IMbrave trial. So these were the subsequent treatments. As we know, once a patient progresses on immunotherapy, the subsequent lines of treatment is what is the difference between the last chemo and there's a platinum-free interval. We can call it as a platinum-free interval. Depending on whether reintroduce the chemotherapy, knock off the immunotherapy. I usually do not use. If there's a florid progression. If it is oligo progression, probably give a radiation, continue same immunotherapy. If it is a florid progression, knock off the immunotherapy and continue the chemotherapy, depending on what your drug we are. So these are the overall key CIT studies in extensive SCLC. Skyscraper trial, and also we have the IMPOWER 133 and also the Keynote 604 trial. So these are all the busy schedule in the first line and this first line maintenance, and now we have the combination of lurbinectedin plus atezolizumab as a maintenance has shown overall survival advantage. So that is definitely one of the things which we need to note down. And in the second and third line, there are a lot of things happening in this particular untreated segment. So this is the frontline chemo immunotherapy SCLC summary, which is showing that there's a OS advantage and the PFS advantage with all the parameters. If you can see, compare at around 3 years, they stand equal in terms of efficacy. So atezo plus versus, if you compare the atezo versus durva, though it is a cross-trial comparison, it should not be done. In general, the blinded trial is regarded as being less subject to bias. So it is the iEmpower is a double-blind trial, and the Caspian is an open label. And if you can see the brain metastasis, the treated asymptomatic metastases were enrolled in iEmpower, and however, the meta-analysis has shown that the comparable efficacy of carbo, it's better tolerated. Only 25% of the patients received cisplatin Caspian, which we usually talk about, and where it contained both carbo and the cisplatin. And you can just see the permitted PCI in this particular patient. So permitting during maintenance, Durva was not given a permission in that maintenance trial. To summarize, Atezo-Carbo A2 was the first major treatment advance in the first line is extensive stage in CLC in 20 years to show the clinically meaningful improvement in the OS over the current standard of care. And meaningful, the updated the median OS was 12.3 versus 10.3 months with a hazard of 0.76 favoring atezolizumab. And the data for iEmpower 133 and Umbrella A provide a first report of 5-year survival outcomes in extensive stage CLC. That's around 12%. The safety profile of Atezo and Carbo Etopo was expected with no new findings and is really one of the well-tolerated IO as we have used it extensively. Atezo Carbo E2 combination is recommended as per the various guidelines as a preferred approach in extensive stage SCLC. So this is what we have today, and thank you very much.
Thank you, sir, for this enlightening session about extended stage SCLC and role of Tecentriq in this. Sir, any preference over platinum drug, carboplatin or cisplatin? What do you prefer? Or people have been using carboplatin, replacing cisplatin with carboplatin. Do you think that it translates into some sort of you can compare about the outcomes while using cisplatin or carboplatin? As most of the patients who are in extended stage SCLC are really frail, and most of them are cisplatin ineligible. So apart from immunotherapy, is there any, from your experience?
No difference in either you use carbo or cisplatin. Only two scenarios. Again, I usually get the clinical picture into a picture as you see. And if a patient has multiple liver metastasis, multiple bone metastasis, that's a scenario where you probably use the cisplatin so that they tolerate it well and the myelosuppression is less. So otherwise, I don't see any difference between the two.
Thank you, sir. Thank you, sir, for joining us.
Okay.
So wait for 1 minute. Aditya sir will be joining. So moving ahead, Dr. Aditya sir joined.
Yes. Good evening, everybody.
So Dr. Aditya Sareen, I think needs no introduction. One of the most dynamic medical oncologists, upcoming dynamic medical oncologist of Delhi. So he'll be speaking on role of cetuximab in recurrent head and neck cancer. Handing over the screen and mic to Dr. Aditya Sareen. Thank you.
So thank you, Dr. Abhinav, very much for this kind introduction, and thank organizers. And obviously, this talk disclaimer that this was being supposed to be taken by Dr. Abhishek, my dear friend. Now I will be doing his place, and he'll be taking my session. Okay. So, response or survival or both in recurrent or metastatic head and neck cancer. Next slide. So let me just, yeah. So for, Indian patients, oral cavity is one of the most predominant tumor with 62% predominance, along with high tumor burden. 80% of Indian squamous cell carcinoma presents the way that is being shown over here. And you need, treatment. And in fact, a faster treatment is required because when they present to us, they are 80% of them are symptomatic. Next slide. So, with highly symptomatic patients, patient expectation should be considered. And the normal question that when will it reduce, what to swallow, and when to taste the food, want to live longer, all those questions, they are in the same group. And at the end of the day, the TMH trial did say that everybody wants to have a symptomatic relief first, majority of them, followed by a prolongation of life. Next slide. Determining role of various therapies in oral cavity. Next slide. So if we were to see, oral cavity constitutes 2/3 of the Indian head and neck cancer patients, and lip and oral cavity are the most common site of cancer in India. Amongst these cancers, head and neck cancer, that is being led by 62%. That tantamounts to 1.3 lakh new patients per year. And next slide. So if we were to look into the snapshot, you can just see the combination of Arbitux along with the chemo has given us a significant improvement in terms of extreme phase 3 trial with an OS improvement. And if we were to compare the primary tumor size, again, oral cavity has shown the maximum survival to the tunes of 20 months. Then study by Dr. Ankur, again 12.2 months. Then we have Dr. Chandrakant, 18 months, and Dr. Kaushal, 20 months. And change to phase 3 trial, again, oral cavity showed a benefit of only 2 to 3 months in the terms of the chemotherapy alone. So next slide. So the North India Tertiary Care Center, the real experience, which was the trial was being led by Dr. Ankur, and you can see the majority of patients did tantamount to oral cavity, having PS2 or 3 in 25% of patients, and ORR to the tunes of 63%. Next slide. And again, the ORR 74% and chemo along with cetuximab has given a fantastic OS benefit of 12.3%, 12.3 months, and a disease control rate of 84%. If we compare it to larynx, again, the benefit is there in terms of 3 to 4 months, and in oropharynx, again, 6 months more beneficial. Next slide. Now, if we were to look at the subset where chemotherapy in oral cavity as compared to cetuximab along with the chemo, you can just see, I think this forest plot is self-explanatory. You can see oral cavity with the hazards of 0.528, and with the rest of them, it is crossing the line of unity, and in patients with oropharynx, it is having a confidence interval being longer. Right, Lilena bhaiya se? Bilkul right. Next slide. So in oral cavity patients, with patients who are on Arbitux and cetuximab, you can see once the bifurcation was done in patients who are having CPS of less than 20 or more than 20, you can see the PFS benefit of 8 months, with patients with more than 20, again 8 months, and median OS being overall of 20 months. So outcomes in oral cavity patient with Arbitux and cetuximab did not differ significantly irrespective of the CPS score. Next slide. And oral cavity cancers present with high immunosuppressive cells may affect the treatment response with the checkpoint inhibitor. And you can see, we all know about this tumor microenvironment. I think we can just change to the next slide. So patients with oral cavity and recurrent disease does not benefit from immune checkpoint inhibitor in with or without chemo. So this was a JAMA trial which was done, and again a cross-trial comparison where ideally should not be done. But if we were to look at the forest plot, the immuno arm in such subgroup is showing a no significant benefit. In fact, it is crossing the line of unity. Next slide. So for faster response, next slide. you can see that the significant symptomatic improvement as soon as the third cycle with cetuximab starts. I think the patient's quality of life improved, right, left, and problems related to the social contact, social eating, speech problem, all they get better once they start with cetuximab along with the chemotherapy. Next slide. बस यहीं रुक जाओ. आगे वाले पे. Right. So coming on to the ORR. Think go back to the previous slide. Yeah. So the treatment response lowers the tumor symptomatic burden in recurrent or metastatic head and neck cancer, and it changes in the overall symptom burden, responders and non-responders. So next slide. And ORR is linked to improved symptom and is better survival outcome. So patients in need of response may benefit from chemotherapy. And I think even in our clinical practice, we feel that combination of the cetuximab along with Erbitux has given us the best benefit over here. Next slide. Yeah, ये count करना. So irrespective of the CPS score, consistent efficacy is observed with Erbitux, and patients who were having low CPX or high CPX, it really didn't matter for cetuximab, but obviously we all know for Pembro it did. Next slide. So just a second, I'll be taking a pause for 2 seconds. Just like. Yes, so compared with extreme, ORR was lower and PD was high with pembrolizumab monotherapy in Keynote 048. And you can see patients who are having a CPS of more than 10, I think the ORR is to the tune of 36% in that subgroup. And patients having CPS of more than 1, your ORR is 35%. And now compared to the Pembro monotherapy arm, your ORR rates dipped down to only 23%. So you can see if you compare the targeted therapy along with the immunotherapy, so you can have your reservations and definitely you need to find better patient selection in such scenarios. Next slide. And in Keynote 048, almost double the rate of PD with the pembrolizumab than with extreme. Next slide. So Erbitux with chemo in recurrent metastatic head and neck squamous cell cancer provided 98% response rate, irrespective of the CPS. So I think that is the main clinch over here, that if you want a faster and a longer recovery, this combination is the way to go. And PFS and OS did not differ significantly between the CPS of less than 20 and CPS of more than 20. Next slide. And patients with larger tumor may benefit less from ICI, so that we all know. Next slide. The next slide. Yes, so the risk factors, go back to the previous one. So tumor burden is significantly correlated with survival in patients with head and neck squamous cell cancer, PD-L1, and tumor burden should be taken into consideration while determining the first-line treatment. Erbitux with chemo is preferred regime irrespective of the PD-L1 status. Next slide. And you can just see in the NCCN as well that the combination of cetuximab with platinum is there in the others recommended regime. But I think that in our practice that we are following, if a patient is having a bulky disease or a high tumor bulk is there, I think I'm happy to start with cetuximab with chemo. Next slide. So So I think you can just switch to the last 2-3 slides. In the interest of time, I need to wrap it up quickly. So that this thing I have already discussed, that whether the CPS is 1 to 19, the cetuximab effect is irrespective. Obviously, you can see how immunotherapy is working, and it is sequentially rising as compared to the cetuximab. Next slide. And hyperprogressive disease was observed in 15% of the patients. And this was the trial shown from Taiwan. And obviously, you need to be on lookout. And obviously, there is no such thing with Erbitux. Next slide. And in Keynote 048, there was no OS benefit in the overall population of the Asian subgroup. So that is one pointer against the IO. Next slide. So some decision factors while choosing patient: if a patient is having a bulky tumor with necrosis, rapidly growing tumor, requiring rapid symptom relieving, regional recurrence after RT, I think your go-to combination is cetuximab with the chemo. And only patient who has a small tumor burden, I think that is the only patient where I will be going with the IO with the chemo. Next slide. So this we have already discussed. Next slide. Next slide. This we all know what is the mode of action. It is the direct effect on the EGFR induced tumor cell death. Next slide. So if we were to consider in the snapshot, the TP extreme regime, you have a median OS of 21 months. And if we compare in the Indian setting, you have a median OS of 23.7 months. And if we were to see across the trials of India, it is ranging from 19 to 22 months. Next slide. Higher ORR and OS was achieved with cetuximab, followed by second-line IO, which may be considered in patients with a large tumor burden and urgent need for treatment responses. Next slide. So for Indian patients, I think weekly paclitaxel with Erbitux followed by nivolumab, one of the trials done by Dr. M.V. Chandrakant, which has shown an ORR of 80% and PFS of 7%, and patients on second line was then given Opdita along with OMCT. Next slide. Can I have the next slide? Yeah, so in the Opdita arm, it showed a median OS of 20 months, and whereas in the arm, it is hardly in the single digit. And low dose nivolumab may not be optimal treatment approach for all the recurrent metastatic squamous cell carcinoma. It is going to work in only in 3 patients out of 10. So you need to be very careful when you are selecting your patients on OMCT. Next slide. Next slide. I think, can you just conclude my slide? Yeah. So each patient with recurrent or metastatic squamous cell carcinoma is unique. Treatment decision should be based on the patient. 80% of patients have high tumor mutation, high tumor burden, are symptomatic. So this combination, Erbitux with cetuximab, provides significant symptomatic improvement. And the factors which I have already discussed in the previous slides, they contribute to the maximum in our selection of the drug, like tumor site, tumor burden, phase of disease, biomarker status. And it's not that costly as compared to the IO. So it's a go-to-go drug, targeted drug for our patients. Thank you. Back to organizers.
So thank you, Dr. Aditya, for extensive talk on recurrent head and neck cancer. As we know, we all have patients full in OPD with recurrent head and neck cancer, and we have only 2 options: whether to go with cetuximab or whether to go with any immunotherapy. So I think
Yeah.
all our understanding is that if you want a faster response, you go with cetuximab. If you want a durable response, you go with immunotherapy. But I think even the patients on cetuximab do have a durable response. The only issue what we face is the side effect profile of cetuximab. A lot of patients already head and neck will have a lot of rashes, skin
Yes.
toxicity. In immunotherapy, you see less side effects. But I think
Absolutely.
the PDL1 testing plays an important role. If you know, if you have head and neck cancer with PDL1 CPS
Yeah.
score more than 50, I think you should go with immunotherapy. Still, but there is a lot of burden of the tumor. There's you know, you want a faster response and you want there's more disease. So we should go with cetuximab.
Yes, absolutely.
Okay. Thank you, sir, for joining us. Now let's
Thank you. Thank you.
another session. Organizing team, Dr. Rajat Bajaj has joined.
No, sir.
Okay. So if Dr.
So
Rajat
can I
Bajaj,
invite you, sir?
yes, okay. So if Dr. Rajat Bajaj has not joined, I will go ahead with, you know,
Okay, so moving ahead for the next session, and this session sponsored by Intas. And I would like to invite Dr. Abhinav Navaria, sir, for give his talk. 1 second, I'll open your PPT. Sir, is it visible?
okay, Gitika. So I'll be talking about serplulimab in extended stage small cell lung carcinoma and beyond. So serplulimab is like our new hero in the town. It has been launched by Dharma Productions. You know, Intas is Dharma Productions of pharma, pharma in oncology. So talking about serplulimab, what it is and how it has uh, it is going to prove its efficacy in small cell lung cancer and as well as other. So it is approved, it is the only approved PD-1 inhibitor, not the PDL1 like Atezo and Durva. It is the only approved PD-1 inhibitor IO in extended stage small cell lung carcinoma. Astrum 005 phase 3 global trial has shown OS benefit with serplulimab in small cell lung cancer. Cross trial comparison should not be done, but again, if you have a new drug, you can see. So cross trial comparison and ESMO MCBS scoring and approved indication in squamous cell, non-small cell lung carcinoma, and esophageal squamous cell carcinoma. So next slide. Next slide. Next slide. So SCLC epidemiology in India, we all know that lung cancer is the last one, Gitika, last one. Gitika, इससे पहले वाला slide.
That is the first slide.
इसके बाद वाला. Wait, I will share. अगर मुझे
Okay.
एक second. So, can you guys see my screen?
Yes,
Yes,
sir,
look
make
at a
it
full
full
screen.
screen, please.
Yes. So talking about SCLC epidemiology in India, Globocan 2022 lung cancer is the fourth most common. Incidence is 81,000 and 15% of lung cancer are small cell lung cancer, 85 are non-small cell lung cancer. And so extended stage small cell limited, you know, we all, as Dr. Chandgowda also in his last presentation showed that ESCLC, you know, since ages we have been dependent on ETO, CIS, ETO, CARB, second line irinotecan, docetaxel, topotecan for extended stage PCI, thoracic radiotherapy, but still we could not improve the outcomes. The median OS of first line platinum based combination remains to be less than 1 year, whatever we do. So after, you know, now after these traditional chemotherapy and cisplatin, ETO, irinotecan, docetaxel, now comes the PD immunotherapy. These two PDL1 checkpoint inhibitors with platinum and etoposide are approved. IMpower 133 showing the importance of atezolizumab, and Caspian trial which shows the utility of durvalumab in extended stage small cell lung carcinoma. So atezo carbo-eto versus placebo carbo-eto, and then atezo maintenance and placebo maintenance. Endpoint OS and PFS. About Caspian, Durva. It has three arms: Durva plus Tremi plus EP, Durva plus EP. So I'll talk about just Durva plus EP versus EP. So again here 4 cycles. Some people give 6 cycles and then continue durvalumab. Primary endpoint is OS. Phase 3 trials, first line platinum eto plus immune checkpoint inhibitor. Median PFS, if you see 5.2 versus 4.3, 5.1 versus 5.4. So IMpower 133, Caspian 2. So not very impressive PFS benefit. Overall survival, if you see 12.3 versus 10.3, again 13 months versus 10.3 months. Again, we are sticking up to 1 year. So these are the two trials which change a little bit about the treatment of extended stage small cell, and we started using immunotherapy in the first line ESCLC. So these are the HR for OS is 0.70 for the IMpower 133, that is median OS 12.3 versus 10.3, 2 months of OS benefit, and for Caspian it is 13 versus 10.3. So again 2.7 month OS benefit. So these two trials are almost, have similar benefits, just a 2-month overall survival benefit. So what is serplulimab? Serplulimab is a PD-1 receptor inhibitor with a different mode of action. So what I will tell you is that it is a PD-1 from the cis complex with CD28 co-stimulatory receptor, and this localization would bring CD28 associated intracellular kinases. Serplulimab blocks co-clustering of CD28 with PD-1 during T cell activation, better than pembrolizumab. So what I have gone through data of serplulimab is that it causes more durable response. It has less immunogenicity than pembrolizumab, but it has got a more durable response, and it has a little bit different action from other PD-1 inhibitors like pembrolizumab, nivolumab, toripalimab, tislelizumab, and it is a fully human. Those drugs are humanized, but this is a fully human checkpoint inhibitor. So more complex immune activation resulting from dual PDL1, yes, PDL1 and PDL2 pathway inhibition, and PDL1 blockade on T cells prevents interaction with the both PDL1 and PDL2 on the surface of tumor cells. Anti-PDL1 agents interact with PDL1, only partially block this pathway. So what they want to say is that a PD-1 inhibitor is more efficient than tumor cell killing than PDL1, and serplulimab is a PD-1 inhibitor rather than atezolizumab and durvalumab are PDL1 blockers. So additional blockade may elicit a more intense T cell activation, hence a strong anti-tumor response. Coming to serplulimab approval status, so DGCI approved in June 2025 for first line extended stage SCLC, and after that Intas has gone gaga about this drug, and all of us have started using this drug. Most of us are having patients on first or second cycle, and within few months we'll get how this drug is performing. So this is the phase 3 ASTROM 005 study design. So no prior treated extended stage small cell. Serplulimab, the dose is 4.5 mg per kg plus carbo-eto, and then serplulimab to continue 3 weekly until disease progression or D1. So what again we will come. So primary endpoint was OS, and second endpoint were PFS and PFS2, ORR and DOR. So baseline characteristics were all comparable. So if you see the median age was 63 and 62, PDL1 negative TPS, if you see 83.6% versus 81%. So most of the patients were PDL1 negative by TPS, but If you see by CPS 53 versus 51, around 12.9 versus 14.3% had brain metastasis, and 25% on both the arms had liver metastasis. So again, you see serplulimab plus chemotherapy, Asian population 67.4% in the serplulimab plus chemotherapy. This Asian population was not that much in the trials, whether it is IMpower 133 or it is Caspian. So it highlights the Asian population. So most of the patients were ECOG PS1, 81 versus 83. If you see, a 68% Asian population in Astrum, while in IMpower, what I said, 17% and 14%, 14.5 in Caspian. So it, it is a trial which has highlighted more about Asian population. So again, if you see TPS, I told you CPS, 50% were more than CPS1, brain mets. So at the end of the study analysis, 4.5 months OS benefit. If you see 1 year OS rate, 62.5 versus 45.4, 32.2 year, 32.7 versus 16.4, 3 year, 25.3 versus 10.1. So 4 year OS, 21.9% benefit. It is 21.9 versus 7.2. That is around 14% benefit. After median follow-up of 42.4 months, HR for OS is 0.6. Quite impressive, quite impressive. Proportion of patients alive at 4 years is 3 times versus chemo. So OS benefit of 4.5 months, 4-year OS 21.9%, which is quite good in extended stage small cell carcinoma. The first PD-1 inhibitor achieves positive results in international phase 3 clinical trials. So PD-L1 have achieved, but PD-1, first one, HR for OS is 0.63. That means 0.37 reduction in the death rate. So 0.63 HR with the OS benefit of 4.5 months. So Astrum, again you see the forest plot everywhere. The graph, the plot is in the favor of serplulimab. Where you see Asian and non-Asian, for Asian it is the HR is 0.61 versus 0.55. So non-Asian, whether Asian or non-Asian, serplulimab outperforms the placebo group. If you see smokers, more benefit in smokers, 0.45 because of the more immunogenicity in the smokers. Again, in patients with PD-L1 CPS more than 10, the HR goes to be 0.46, which is quite good. And overall HR is 0.60. Serplulimab, okay, again HR for disease progression-free survival, median follow-up 12.3 months. Serplulimab plus chemo versus so median PFS is 5.7 versus 4.3. So 1.4 months PFS benefit 2, and HR is 0.48. Astrum updated safety analysis, again about talking about side effects. Serplulimab and chemotherapy grade 1, 2 side effects as more than grade 3 side effect is 83.3% of patients had more than grade 3 side effects. So this we have to check about the side effect profile. All of us has given only 1 or maybe more than 2 cycles of serplulimab. So serplulimab, I think this we have to see in detail about the side effect profile of serplulimab. Maybe Intas people will help us to guide, help us to let us know more about this. So serplulimab plus chemotherapy has achieved a 3-year OS rate of 24.6, bringing the extended survival benefits to extended. So OS gain 4.7 months. Again, if you see the cross trial comparison, 4.7 versus 2 versus 2.4 months. So again, they have ranked it like, serplulimab versus Atezo versus Durva. So first for OS, first for PS. So again, now Intas is showing that their drug is rank 1 in the class, first for OS, first for PFS. So this is meta-analysis, first for OS, first for PFS. So agree, we are all excited about this new drug for extended stage small cell carcinoma. Let's see how it responds in our patients, and how the more important thing is how its safety profile remains. So MCBS about ESMO, magnitude of clinical benefit scale. So MCBS grading highlights those treatments which are substantially improve the duration of survival and quality of life. So we all know MCBS. So in highest ESMO magnitude of clinical benefit scale in extent. So serplulimab comes in the MCBS score of 4.5 to 5, while atezo durva is 3, tislelizumab is 2. So substantial benefit. So conclusion, okay, we have already concluded that it has a high MCBS score. It has achieved a OS benefit of 4.2 months. So now talking about beyond extended stage small cell lung carcinoma. So again, like in the patient with squamous cell carcinoma lung. Again, which the trial name is Astrum 004 in advanced squamous non-small cell lung cancer. We can compare it to the Keynote 407 trial. I think if I'm not mistaken, it's pembrolizumab for squamous. So again, serplulimab plus nab-paclitaxel versus nab-paclitaxel. Primary endpoint is PFS. So updated PFS is 8.3 months versus 5.7 months, which with a hazard ratio of 0.55, again little bit impressive. And if you see the median overall survival, it is 22.7 as compared to 18.2, almost similar to the Keynote trials. So tumor response, esophageal squamous cell carcinoma, again for patients with our esophageal squamous cell carcinoma, which cannot be cured by surgery or chemo, it is serplulimab plus cisplatin 5-FU versus placebo. And then you continue serplulimab 3 mg per kg. Here the dose is a little bit lower than the lung, and the primary endpoint remains to be PFS. So again, if you see the intent to treat population in PDL1 CPS more than 10 population, the HR in intention to treat population is 0.6. While as in CPS more than 10, it is 0.48. So again, after tislelizumab, serplulimab is also in the line. After you have nivolumab, you have tislelizumab, you have serplulimab. So all these maps are changing the treatment paradigm. We have so much options right now. So overall survival, if you see 15.3 versus 11.8 months, that is a hazard ratio of 0.68 in the intention to treat population, while in PDL1 CPS more than the HR comes out with 0.59, 18.6 versus 13.9 months. Again, showing some benefit. Again, if you see the PAN approval in serplulimab is approved in all the MSI high tumors. So I won't go into the detail. So after this session, I don't think Indus people can tell me if DGC approval is for all the MSI high tumors in India. So these are all the indications. If we talk about China indication, extensive stage squamous cell, lung carcinoma, non-squamous cell, esophageal, MSI high. Phase 3 trials are going on. Phase 2 trials are going on. So thank you. And it was nice to speak about a new drug. Anyone from Indus?
Thank you, sir. No. So they might have joined with the registration link. So
Okay.
they
Sir,
are
Dr.
the-
Rajat sir has been joined now.
Okay.
So,
Maybe 1 minute.
sir, Dr. Shrikant sir joined.
Okay. Shrikant sir has joined.
Yes,
Hi,
sir.
Abhinav. Hi, Abhinav.
Hi, sir. How are you? How's Gopal,
Fine,
sir?
thank you. Hi, it was good. Come on, 8th and 9th. My program is there.
Okay, okay, sir. Okay, sir.
है ना? 8th
So,
and 9th November.
okay, sir. So, welcoming Dr. Shrikant Tiwari. He'll be speaking on ASCO 2025 abstracts on lung cancer. Thank you, sir, for joining us, and handing over the mic and screen to you, sir.
Can someone share my slides?
Gitika, please share the slides.
Okay, sir.
हाँ, slide share कर दो sir.
Please do fast. अरे मुझे गणपति स्थापना में जाना है यार.
Gitika, so in Delhi, आज कोई ऐसा auspicious day नहीं है, but today in MP and Maharashtra, Ganesh Chaturthi है. We have, I
Yeah.
think, it's a very auspicious day, and please do it fast, ताकि वहाँ आज मुंबई बंद रहता है, MP भी बंद है आज almost.
MP, there is official holiday.
हाँ सर. दिल्ली में कोई नहीं मनाता सर.
I know.
Gitika, please share the slides. You don't have the slides or what?
So just 1 minute, I'll share.
Okay, okay.
Yeah, so should I start?
Yes, sir. Yes, sir.
Okay.
Yes, sir.
Okay. Good evening, everyone, and thank you, Abhinav, for the invitations and such a wonderful academic. Yes. So I'm going to present the data of 2 or 3 trials which were presented in ESCO 2025. The first one is this the data of this new EDURA trial. It is the use of osimertinib. We know that the osimertinib has worked excellently in metastatic setting, as well as in the adjuvant setting if the patient is in EGFR mutant. So whether this combination either as a monotherapy or along with the chemotherapy, it will work in neoadjuvant setting or not, the trial will say, the data will say. Next, please. So the background of this trial, we know that in EGFR mutant NSCLC, till now, this neoadjuvant chemotherapy or chemotherapy immunotherapy are the options. But if you see the MPR rate, that is the maximum pathological response rate with this neoadjuvant chemotherapy only or chemotherapy with immunotherapy, are very low. It is around 0 to 10. Chemotherapy will definitely help because it will convert most of the patient to the surgery. And apart from the surgery, there will the other advantage will also happen if you have more effective neoadjuvant therapy, like it will reduces the disease progression, so precluding the surgery. It will improve the surgical outcome because if the tumor the size or the nodal status will be down stage, definitely the surgical outcome will be better, and it will improve the long-term outcome because up to 36% of patients do not receive adjuvant treatment. So if the neoadjuvant treatment is so effective, the benefit is much more. So this phase 3 NeoDura trial will address the same things. Next, please. Yeah, this is the trial design. It was a global randomized phase 3 control study. And the inclusion criteria, they have included stage 2 to stage 3B. So stage 2, stage 3A, and stage 3B. Histologically confirmed non-squamous NSCLC patients. They have included both exon 19 deletion as well as the L858R mutations. And stratification was done on the basis of a stage, whether the patient was a stage 2, a stage 3A, or a stage 3B, whether the patients are Asian, Chinese Asian, or non-Chinese Asian, or non-Asian patients, and on the basis of different type of EGFR mutations. It was the 3-arm study. The randomization was done 1:1. The arm 1 consists of this osimertinib plus chemotherapy. The chemotherapy includes the pemetrexed with carboplatin or cisplatin. The second arm was osimertinib monotherapy, and third arm was the placebo plus chemotherapy. After 3 cycles of chemotherapy, surgery was done, and then it was investigator choice to whether to put patient on adjuvant treatment or not. The primary endpoint of this study was to see the major pathological response by blinded central pathological review, and the secondary endpoint was the event-free survival, pathological complete response, and nodal downstaging and safety. Next. This is the baseline characteristics. In all the 3 arms, the baseline characteristics was well maintained. In all 3 arms, around 50% of patients are either exon 19 deletion or L858R mutations. 50 to 51% of patients are stage 3, and rest 50% are stage 2. If you see the nodal status, most N1 and N2 include around 70% of patients, and N0 patients are around 25 to 30%. Next, please. Surgery after the neoadjuvant chemotherapy, patient underwent surgery. In arm 1, that is osimertinib plus chemotherapy, 92% of patient underwent surgery, of which 91% have R0 resection. In osimertinib monotherapy, 97% patient underwent surgery with 95% R0 resection. But in chemotherapy plus placebo arm, only 89% of patients underwent surgery, and out of that, 93% have R0 resection. Next, please. So if you see the reason for not undergoing or completing surgery, the one of the important reason for not undergoing surgery was the disease progression. And in osimertinib plus chemotherapy arm, there was only 2% patients who preclude, in whom the surgery was not done because of the disease progression. Similarly, with osimertinib monotherapy arm, again the 2%. But in chemotherapy plus placebo arm, there was 8% of patients in whom the surgery was deferred because of the disease progression. Next. Next, please. Yeah. So if you see the major pathological response rate, the MPR rate was statistically significant higher in both osimertinib containing arm. So if you compare arm 1 with arm 3, the differences was around 24%. And with arm 2, that is osimertinib monotherapy with this chemotherapy plus placebo, the difference was around 23%. Next. On subgroup analysis, the subgroup analysis was done with arm 1 and arm 3, and then arm 2 with arm 3. That means the chemotherapy plus osimertinib versus chemotherapy plus placebo, and osimertinib monotherapy versus placebo plus chemotherapy. And if you see the hazard ratio and the data, the across the subgroup, whether the patients are the ACN patients or non-ACN patients, either it is exon 90 deletion or L858 mutations, benefit is seen across all the patients. Although the benefit is much more seen in Chinese ASEAN patients, the benefit is much more in exon 90 deletion compared to the 858R mutation. And if stage wise, the benefit is much more in stage 3 compared to stage 2. Next, please. Next, please. Yeah. So this is water flow part. If you see the depth of pathological response, it was greater in osimertinib containing arm. In osimertinib plus chemotherapy arm, the major pathological response is seen in around 26% of patients, out of which 4% have achieved complete pathological response. In osimertinib monotherapy arm, 25% of patients achieve major pathological response, out of which 9% achieve pathological complete response. Whereas in chemotherapy plus placebo arm, only 2% of patients achieve major pathological response, and none of them achieve complete pathological response. Next. So nodal downstaging, over 50% of patients who have baseline N2 disease in osimertinib containing arm, either osimertinib monotherapy or osimertinib plus chemotherapy, 53% of patients saw downstaging from N2 status, whereas in chemotherapy arm only 21% of patients saw downstaging. Next. interim analysis of this EFS was done in 15% of maturity, and it has been seen that if you see the hazard ratio for osimertinib plus chemotherapy, it is 0.50 in compared to chemotherapy alone, and for osimertinib monotherapy in compared to chemotherapy alone, it was 0.73. Next. Next. So another next, please. Another interim EFS for those patients who have achieved this major pathological response. Next slide, please. Please send next slide. Yeah. So what EFS has shown in those patients who develop MPR, who has achieved MPR, the events of event-free survival is happening in only 2% of patients. Where in those patients in whom MPR has not been achieved, 18% of patients have developed some events in event-free survivals. Next. Safety profile, there is no new safety data. Or if you see all these three arms, none of the patients require dose reduction or dose interruptions, and most of the adverse events happen because of the chemotherapy. So in osimertinib plus chemotherapy, most of the adverse effect happen due to chemotherapy. In placebo plus chemotherapy happen, most of the adverse effect happen due to chemotherapy. So in osimertinib monotherapy, very minimum is grade 3 or more adverse events happen. Next. Next, please. So safety findings were consistent with the known profile of the individual agents. What we know about the osimertinib and the pemetrexed based chemotherapy, safety profile is matched with that. There is no new safety signal has been seen. Next. So to conclusion, this neoadjuvant osimertinib either alone or in combination demonstrated statistically significant improvement in the major pathological response rate versus chemotherapy alone. That is 26% for chemotherapy plus osimertinib, 25% for osimertinib alone versus 2% for chemotherapy. The interim EFS trend favor osimertinib containing regime. Very few patients with MPR had events. So those patients who have achieved MPR have they have very few EFS events, whereas those patients who have not achieved MPR, they have almost 18% of EFS events. Over 50% of patients who are having baseline N2 disease, it has been shown down staging at the time of surgery versus 21% with chemotherapy alone. There was no new safety signal was seen in this patient. Next. No, the next presentation. Please go on the next presentation.
Next abstract, Gitika.
Yeah. No, this was not there. This was not there. You have sent me 3. The another one is this IMFORT trial. The another one is IMFORT trial. One is IMFORT trial, and second is this Delphi 304. Yeah. So this IMFORT trial, this is this lurbinectidine plus atezolizumab as a first-line maintenance treatment in patient with extensive stage small cell lung cancer. Till now, we are not knowing any maintenance therapy like in non-small cell lung cancer. We have a lot of maintenance therapy happens in the form of chemotherapy or anti-VEGF inhibitors and the immunotherapy. But for a small cell lung cancer, there is no after the first line therapy. If the patient have the stable disease or CR/PR achieved, there is no maintenance therapy. So this trial will address for that patients. Next, please. Next. Yeah. So background of this trial. So despite improved efficacy with the first line immune checkpoint inhibitors plus platinum based therapy, most patients with extensive stage small cell lung cancer eventually experience disease progression and long-term survival still remain limited. So due to high attrition rate in extensive stage small cell lung cancer, of around 60%, offering the most effective treatment in the first frontline setting before progression is crucial to improve outcome in such a difficult disease. This lubitriptanab it is basically alkylating agent with transcription inhibitor that is approved in US and other countries for the treatment of patients with metastatic SCLC who have progressed on the first line platinum based therapy. In preclinical study, it has been seen that this lubri, when it was given along with the immune checkpoint inhibitors, they have synergistic effect to achieve high rate of tumor regression and induce the long term the T cell memory. Next, please. So this is the study design. So first screening after the patients have been extensive stage small cell lung cancer. CNS metastatic patient has been excluded from the study. And after the entering from this first screening, the patient has received the 4 cycle of etoposide carboplatin plus atezolizumab. This phase was called induction phase. After 4 cycles, again re-evaluation is done with the second screening. And the patient entered in this IM4 study were those patients who has achieved either CR, PR or at least a stable disease following induction therapy and still have ECOG PS 0 to 1. So such patients were randomized 1:1. One arm the patient received lubri plus atezolizumab and second arm atezolizumab. The treatment was continued till the disease progression or unacceptable toxicity. Crossover was not allowed in this study. The primary endpoint was the PFS and OS, and secondary endpoint was the overall response rate, duration of response, and safety. Next, please. Next, yeah. Go next. This is the statistical plan. Next. Next, please. So, see, this is the baseline demographic profile. The patients included in this trial, most of the patients were Caucasians. Around 80% of patients were Caucasian, and Asians population were only 12.8%. The patients included were both current and previously tobacco user. Liver metastasis at the time of induction, if you see 41.3% of patients in lubri plus atezo arm and around 39% in atezo arm have liver metastasis at the time of diagnosis. LDH was taken as a stratification factor in this case, whether the LDH level was more than upper normal limit or less than upper normal limit. Around 87% of patients who have included in this study were achieved CR and PR with induction treatment, and 11.9% of patients have stable disease. Next. Now, if you see the PFS, the median PFS is around 5.4 months versus 2.1 months. And if you see the PFS at 12 months, it is 20.5% for lubri plus atezo versus 12% for atezo. Next. Next. On subgroup analysis, the benefit is seen across the subgroup of patients, with some patients respond better in compared to other patients, like those patients who have history of smoking, but previous history of smoking, but currently they have stopped smoking. They respond better than the current smoker. If the patient is having liver metastasis, they respond better in compared to those patients who are not having liver metastasis baseline. Those patients who have received prior PCI, they are not doing better compared to those patients who have not received PCI. If the baseline LDH level is lesser, such patients do better. And similarly, those patients who have achieved CR or PR in induction periods, they do also better in compared to those patients who are having a stable disease. Next. The OS data, the median OS is 13.2 months versus 10.6 months with hazard ratio of 0.73. And if you see the 12-month OS data, it is 56.3% for lubri plus atezo versus 44.1% for atezolizumab. Next. This is and this data is the OS from the randomization into the maintenance phase. So this 13.2 month has not included the induction treatment where the patient has received 4 cycle of chemotherapy plus immunotherapy. So that also include 3.2 months. So that so if you are calculating the OS, that period should also be included in the OS. Next. Subgroup analysis, same picture as the seen in the subgroup analysis of the PFS. Similarly, almost all type of patients benefited, bearing few patients like those patients who have received prior PCI, they do not do better in compared to those patients who have not received PCI. Otherwise, almost all the patients do better in compared to only those patients who have received this atezolizumab. Next, please. This is the overall response rate and duration of response. If you see the confirmed objective response rate in Lubri plus Atezo arm, it is 19.4% versus 10.4% in Atezo arm. So the difference of overall response rate is around 9. The duration of response, the median duration of response is almost double in case of Lubri plus Atezo. So in Lubri plus Atezo, it is 9 months compared to 5.6 months in Atezo. Next. Next, please. Next. Go next. Yeah, safety files, that is very important because this Lubri is a drugs which are a lot of adverse effects, and so one of the drugs we have not used till now. Once it will come in the market, then we'll see how it will work and how the patient tolerate it. But if you see the data, the grade 3-4 adverse events seen in around 38% in Lubri plus Atezo versus 22% in Atezo arm. The treatment-related grade 3-4 adverse events, 25.6% in Lubri plus Atezo versus 5.8%. The grade 5 adverse events, 5% versus 2.5%. The serious adverse events seen in around 31% of patients who are on Lubri plus Atezo versus 17.1%. The treatment discontinuation is required in 6.2% versus 3.3%, and the drug modification and drug interruptions were required in 38% of patients versus only 13% of patients who are receiving only atezolizumab. Next, please. So difficult drug to tolerate. This is the adverse effect profile. Most of the adverse effects profiles are hematological and GI related. So hematological patients may have anemia, thrombocytopenia, or neutropenia, and GI side effects that includes the nausea, vomiting, decreased appetite, fatigue, as well as the constipation. Next. So to conclude, this IM4, it demonstrated a statistically significant and clinically meaningful improvement in the PFS and OS as a first-line maintenance treatment with this Lubri plus atezolizumab versus atezolizumab in patients with extensive stage small cell lung cancer. The PFS hazard ratio is 0.54 and OS hazard ratio is 0.73. Both PFS and OS benefit was seen across majority of the subgroup of patients. The adverse effect, grade 3-4 adverse effects has been seen in most of the patients. But if you see the safety profile, most of the safety profiles are predictable, and most of the safety adverse effects are generally low grade and easily manageable. Thank you. Dr. Abhinav.
Sir.
Dr. Abhinav, are you hearing me?
Yes, sir.
Can I conclude it? I have to go there, yeah.
Yes, sure, sir.
Yeah.
Already
so third
sir
one is
has
left.
covered about neoadjuvant osimertinib and small cell lurbinectedin maintenance therapy. Thank you, sir, for joining us.
Thank you.
What I want to say is that for neoadjuvant osimertinib, I think we need more data.
Yeah.
And lurbinectedin.
I think. Yeah,
Yes.
please tell me.
And for lurbinectedin, the drug is not yet in the market, but as soon as it comes, let's try, because in small cell lung cancer, after etocarbo and a few of immunotherapies, we don't have much options, right?
Yeah.
Okay,
But
thank you, sir,
the
for
only
joining
thing is that it is difficult to tolerate, because if you see the data of adverse effects, I
Yes,
don't know what will happen, but it will be difficult to tolerate.
Yes, sir.
Yeah. Thank you, Abhinav. Thank you.
Thank you, sir. Thank you for joining us, sir. So moving on to next session, Dr. Tarachandran has joined.
Yes, Dr. Abhinav. I'm
Good
here.
evening, sir. Good evening, sir. Thank you for joining us. We have Dr. Tarachan Gupta, who is from Jaipur. He's a senior medical oncologist, and he will be speaking on low-dose nivolumab in recurrent head and neck cancer. Which has become a standard of practice for us, because in a resource-limited country like India, where patient cannot afford immunotherapy, a low-dose immunotherapy, low-dose nivolumab has saved a lot of patients along with OMCT. So handing over to you, sir. Thank you for joining us.
Uh, Thank you, Dr. Abhinay, for the nice introduction. Now, Dr. Geetika, can you run my slides, please? So today we are talking just a hot topic of the that is accepted globally is the low dose immunotherapy in head and neck cancer. Before that, we will go for the background. Please, next slide. So head and neck cancer, we know that this is a difficult to treat the disease, and especially when it is in advanced setting or in recurrent setting. Before the introduction of these biological therapies, hardly patients were surviving for the 6 months only. So next slide, please. So first trial that come over the conventional chemotherapy was the extreme regimen. That was the chemotherapy plus cetuximab with the cetuximab. That was the cisplatin 5-FU. Later on, it was replaced by the docetaxel, cisplatin, and the cetuximab. Here, the cetuximab shows the clear-cut overall survival advantage of 2.7 months with a 20% reduction in the death, and 1 year overall survival first time crossed to the 20%. Next slide, please. So later on, then when we were not having a 1 year survival median, then the immune checkpoint inhibitors came into the picture, and they showed the continued response as in other disease. So we have in this as of now in the head and neck is the pembrolizumab and nivolumab. So next. So first was a checkpoint 141 trial that nivolumab was tested in the second line. That means the either disease progress on the platinum or patient was refractory to the refractory or resistant to the platinum. Those has progressed within 6 months of concurrent chemoradiation. Nivolumab was tried in the 3 milligram per kilogram and 2 weekly doses, and it was open irrespective of PDL1. Next. So this is the graph where it is showing that there was a benefit of around 5.5 versus 7.7 months of overall survival with the new addition of nivolumab, and 2 year survival crossed to the 15.3%, and 1 year survival first time reached around 35% with addition of nivolumab, and 2 year survival is 66 versus 16.9%. Next. So we can see it was in HPV positive OS was 7.5 versus 5.8 months, and HPV negative, and HPV positive it was OS 9.1 month versus 4.4 month. PD-L1 expression associated with the increased overall survival. The next line. Next trial in the came with the Keynote 048 study design, where the pembrolizumab was tried in the first line setting with in comparison to the at the current standard of that time, it was the extreme regimen, where the pembrolizumab tested pembrolizumab alone in a high PD-L1 positive patients, and pembrolizumab plus chemotherapy versus cetuximab plus chemotherapy till progression or the more maximum 35 cycles of pembrolizumab. Next slide, please. So next slide, please. Next slide, please. So this is the overall survival. We can see the pembrolizumab that is around. We can see that there is a 10.7 versus 11.5 month in favor of pembrolizumab with 19% reduction in the death. At 2 year, the survival is 19 versus 27, and first time we are seeing the 4 year survival is around 15% in pembrolizumab. Next slide, please. So then it is we can divide along with the PD-L1 score, where the CPS 20 or more than 20, it was pembrolizumab versus cetuximab chemotherapy. Again, the survival benefit favors the pembrolizumab single agent 14.9 versus 10.8, with the 39% decrease in the death. And it is 4-year survival in this arm where the PD-L1 score is good. It is 8 versus 21%. And in a CPS1 or more than one, it is 20 pembrolizumab single agent was 28.9 versus 17.7% in favor of pembrolizumab, and 4-year it is around 6.9 versus 16.7%. Next slide, please. Next slide, please. Next slide, please. So this is now the pembrolizumab with chemotherapy versus cetuximab. That means the extreme regimen. 13 versus 10.7 months is the median overall survival with 29% reduction in the death. At 2-year, the survival rate was 18.4 versus 29.4%. And at 4-year, it is 4.5% versus 19.4% in favor of pembrolizumab. Next. So for the CPS 20 or more than 20, that is around 14.7 versus 11.1, around 38% reduction in death. That means more beneficial even with the chemotherapy arm. And if we can see at the 2-year survival rate is around 20 versus 35%, and at 4-year it is 6 versus 26%. For CPS 1 more than 1, that means less than 20. Pembrolizumab plus chemotherapy arm did better, around 13.6 versus 10.6 month, in comparison to the extreme regimen, and with a hazard ratio of 0.64, and 2-year survival is around 17 versus 13.8%, and 4-year survival is 21.8% versus 4.1%. Beauty of this trial is the control arm works as the like historical trial. Next. So what is the concept of low dose immunotherapy, where the pharmacodynamics is relatively new term which uses economics, pharmacological and pharmacodynamics property of drugs to propose less expensive alternatives to standard treatment. This helps to increase access to the effective therapy. That's why the low dose immunotherapy came into the picture. Next. So strategies for achieving near equivalent outcomes. What qualities a drug should have? Prescribing a lower dose if the approved dose exceeds that the needed for the maximum anti-tumor activity. So this is in contrast to the chemotherapy trial where the maximum tolerable dose is the dose for the chemotherapy. Here it is the maximum anti-tumor activity is the dose of immunotherapy and the low dose. Less frequent dosing of the drug where pharmacokinetics and pharmacodynamic data suggest the longer interval are appropriate. Prescribing a shorter course of treatment, improving oral drug absorption by food intake or with another agent that enhances viability. We have seen in the case of ceritinib and abiraterone, giving an alternative, less expensive drug with the similar efficacy. Next slide. So this is the safety, activity, and immune correlates of the anti-PD-L1 antibody in cancer. We can see that there is no new safety signal for the if we are using at the frequent, more frequent interval or more frequent interval, or that means low dose, because it is not affecting. Even that maybe less toxicity can be observed. The less toxicity in terms of financial toxicity, in terms of time toxicity, and in terms of some infusion reaction and immune-related reactions. Next. So low-dose nivolumab can be effective in non-small cell lung cancer also. There is a Chinese study is there, and where we can find that the low dose was not inferior to the standard dose in all terms of response rate or progression-free survival, overall survival, and treatment duration, where all time the p-value is not significant. Next slide, please. So this is a TMH study where there are 71 patients in the database were evaluated for the results of the low dose nivolumab in the different tumor types, where we can see that the median age was the 46, and the female that means 85% were male, and prior lines of therapy were maximum is around 1 line of therapy, and disease sites were the urinary bladder, renal, lung, and head and neck. That was the most common tumor in this pool. And if we see the results of this low dose immunotherapy, there was the 6-month progression-free survival was 100% in the low dose nivolumab versus 8.7%. And overall survival is 100% versus 29.7%. And the treatment was well tolerated. Next slide, please. So this is the low dose immunotherapy that goes by blockbuster in the globally, and this is very close to my heart. It is patient was allotted to the standard arm with the triple metronomic chemotherapy, where the celecoxib 200 mg twice daily, erlotinib was the 150 mg, and methotrexate 9 mg per meter square once a week. Along with the in experimental arm, it was combined with the low dose immunotherapy, that is nivolumab 20 mg every 3 weeks, which was administered in 100 ml normal saline over 60 minutes. Next slide, please. So this is a consortium diagram. We can see everywhere how the patient flows in this trial. Next slide, please. So these are the baseline characteristics. Those were well matched in the both arms. Next slide, please. So this is the PFS. We can see in the triple metronomic chemotherapy arm and in combination arm where the low dose nivolumab was given, where the 66 events in the TMC arm and 52 events in the TMC-I arm for the PFS. Median PFS in TMC and TMC-I arm was 4.6 versus 6.6 month. And the addition of low dose nivolumab to TMC decreased the hazard of progression to the 0.56, that means 44% reduction. Next. There were 9 in the, we see the overall survival. 1 year overall survival was 16.3 versus 43.4 in favor of low dose nivolumab combination with a hazard ratio of 0.54. Median OS in TMC and TMC arm was 6.7 month versus 10.1 month that coincide with the extreme regimen. The next slide. So this is the forest plot. We can see, except that the previous, if the platinum therapy was, it is more work in second line therapy, most probably. And because the maximum patients were in second line, and this was the second line trial only. And the time to failure in month, if it was more than 12 months, also that regimen did not work. That means the platinum in the platinum sensitive disease regimen is quite less effective. Next line. Response rate in TMC and TMC arm was 45.3 versus 59%. The median duration of response was 3.3 versus 8.7 months. Among patients in the TMC arm, the median duration of response was not reached in patient with the PD-L1 score more than 50%, as opposed to being 8.1 months in the PD-L1 score below 50% or unknown. Next slide, please. So this is the side effect which are well missed, which are well known and compatible with the immunotherapy arm and immunotherapy per se and the metronomic. There were no new safety signal, although the one thing which happened in this trial was the mucositis was more where the TMC regimen was used, and appearance of rash was quite early. Next slide, please. This is where the quality of life was well maintained in the TMC arm, and it was better than TMC because wherever the progression-free survival is better, then usually patients have the productive life and quite good quality of life and ambulatory life. Next. So this is the annual cost, which according to which this regimen was planned, where the if we say that the Indian VSA is nearby 1.5 kilogram per meter square, so we can see that the TMC regimen is 4,370.1 US dollar. That means 3,31,472 Indian rupees. For Keynote, it is 81,711. That means the 61,97,000 for the, and for the extreme, it is 35,39,000. For single agent nivolumab, it is 48,34,830 rupees at that time. And for the single agent pembrolizumab, it is 61,85,000. So the use of TMCI regimen decrease the cost of therapy to the 5 to 9% of the cost of full dose immunotherapy regimen. Next slide, please. So to conclude, the immunotherapy is one of the effective treatment option in the management of recurrent and metastatic head and neck cancer. Low-dose immunotherapy had shown its efficacy across many solid tumors and in head and neck cancer in randomized study. Use of low-dose immunotherapy significantly decreases the financial burden on the patient without much compromising the efficacy. And lastly, I can say कि yes, मूंगफली गरीब आदमी का बादाम है. Thank you.
Thank you, sir. Thank you, sir, for enlightening and emphasizing on the low dose immunotherapy. The last line, "Moongfali garib aadmi ka badam" hai, exactly. So any patient who benefits with this low dose immunotherapy, thanks to the researchers who have published this data, and really we are, we have put this in our practice like anything, and low dose immunotherapy works really well with OMCT in head and neck cancer. So one question before leaving, do you test for PD-L1 before using low dose immunotherapy?
No, it is not required. Even we have the data of 27 patients, and we can say it's a retrospective setting where the PFS was around 70% for the 6 months, and even the OS was also same 70% at 6 months.
Again, so we don't need any PD-L1 report for low dose.
No, it's not. It's not required.
That's what I'm saying. No need to do a PD-L1.
Yeah.
Thank you, sir. Thank you for joining. So concluding today's webinar, thank you everyone for joining. Thank you technical and support team. Thank you all the sponsors for making this webinar possible. And let's meet tomorrow on the second day of our common cancers, advancement in common cancer. Geetika, can we sign off?
Yes, sir. Thank you so much, Dr. Abhinav and Dr. Tarjan, and all the delegates in Palmer to join today's session. Please join us for tomorrow's session also. So, tech support, thank you, and Jalak, thank you. And tech support, can you please close the meeting?
Thank you.